Feel free. So again, good morning. My name is Mike Randol. I'm the Medicaid Director for the state of Iowa. I believe there were a couple of other updates, but I think I'll probably just go straight to, why everyone is here, kind of walk through the cost projections and the cost saving analysis. I'll kind of go through the analysis and the methodology, and then I'm sure we'll have time for questions from the council at that point as well. So really what we were looking at is cost in the Medicaid program overall, with and without the managed care organizations. So what we were looking at is determining and establishing base expenditures. So when we look at without the MCO methodology or without the MCO delivery model, we looked at state fiscal year 15 as the base expenditure period, since it was really the last complete year under the previous Medicaid system, so the fee-for-service. We did not choose state fiscal year 16 because that was 9 months of managed care and initial implementation and then 3 months of fee-for-service. So we felt it were more appropriate to go back to state fiscal year and have a full year of basically the fee-for-service or without managed care. The state fiscal year base period expenditures, which were actual expenditures, were trended to state fiscal year 18 using a 5% annual trend rate. That trend rate is based on actual Medicaid program trends, actual expenditures from state fiscal year 11 through state fiscal year 15. We also wanted to make sure we were conservative in our approach. So we wanted to make sure that when we took a look at the trend factor that we used, that we were looking at an appropriate trend factor. So the Iowa Health and Wellness Plan expenditures, they were excluded from that trend calculation. Obviously excluded because as you had that population enter into the Medicaid program, it spiked the expenditures. So we felt it was more appropriate not to include those in that analysis. And also we made adjustments to state fiscal year 18 trend rate to account for strategies implemented in that fiscal year, and also those expenditures that weren't really going to be included until the following year. So there were different things that we want to make sure from an accounting perspective, so to speak, that we're matching those expenditures to the appropriate fiscal year.
Did you include the FMAP changes as well?
Yes, and that's one of the reasons we went to total Medicaid expenditures, so that from an isolation factor, taking a look at the specific components.
So how much feds, how much state?
Exactly. So it's total. So we're looking at total Medicaid expenditures prior and then total Medicaid expenditures after. Because you not only have state general revenue, you have federal funds, you also have fee funds. So we want to make sure that it does complicate the calculation when you try to isolate some of those factors. So we felt it more appropriate, and I felt it more appropriate, working with our finance folks too, that we just include total cost of the Medicaid program overall. So with the MCO methodology, those base expenditures represent state fiscal year 17 expenditures that were recorded in the state's accounting system. And then adjustments were made to account for those 17 managed care payment obligations that really will not be paid until a future period. So again, we want to make sure we have apples to apples, because when I came here, we want to make sure we have an appropriate comparison when you have apples to apples from a managed care perspective, and I think they were comparing fee-for-service. So I felt it more appropriate to take a look at, let's look at our Medicaid program as a whole prior to the implementation of managed care, and our total Medicaid program after implementation of managed care. It's a significant component of the Medicaid program, but it's not appropriate really to compare fee-for-service to a managed care. It's Medicaid to Medicaid. So that was the goal of going through this additional analysis. The base expenditures for state fiscal year 18, the base expenditures represent the December 2017 estimate. So when you take a look at the state fiscal year 18 Medicaid program spending, what we believe we will spend, it's based on what our projection was December of 2017. So then when you take a look at the savings or the cost avoidance, the total savings were calculated as a difference between the without MCO and the with MCO. And the state savings were calculated by multiplying total savings by the average state match rate for the applicable years. So we had that total cost avoidance dollar, but we wanted to see what the impact for state general revenue was too. So that's where we looked at the FMAP percentage and said, here's how much of that total is general revenue. I think it's important to understand that regardless of the methodology, that there are savings, and the appropriate, as I first came here, I always said that, my focus is on 650, 670,000 Iowans. And we have to make sure we have a sustainable program in the future. Not 6 months from now, not 12 months from now, but 3 years, 5 years, and 10 years from now. So you have to have that sustainable program. And to do that, you have to be able to manage the care and manage the appropriate costs within the program. And so with the managed care delivery model, I believe that is what we were seeing. So with that, I will be happy to answer questions.
Anybody have a question? So you're saying there are savings, but what are the savings?
The projected savings are about $140.9 million for state fiscal year 18.
So does that include, we still have a certain percentage of people that are on fee-for-service. Does that include the people that are on fee-for-service?
Yes, that's one of the reasons we went to, and not really comparing fee-for-service to managed care. Let's take a look at the total Medicaid program. Prior to implementation of managed care,
Yeah.
how do we look at a total Medicaid program after implementation of managed care? So yes, it includes the entire Medicaid program.
So I'm hearing what you're saying, and I understand, but what I would like to see is what was actual fiscal year 15 expenditure, and what does 5% trend rate calculate out to?
So when you take a look at without MCO for state fiscal year 15, it's about $4.9 billion.
That's an estimate. of
That would be-
What you would have projected, or
It's-
we wouldn't have.
It's about $4.9 billion, is that we actually have the state fiscal year 15 expenditures.
Okay.
So we spent 4.9 billion.
Without MCO.
So does that also, I'm sorry, does that also include people that have not received their reimbursement? Because we've had lots of folks that didn't get reimbursed.
Well, state fiscal year 15 is prior to
15
implementation.
would have been, yeah, 15, I'm
Correct.
not asking about that, but the savings. So is that people that also include claims that haven't been resolved?
For state fiscal year 18, the projected
Right.
savings, 140, that's the projected savings based on what we felt we would spend in the program in December of
But it
2017.
doesn't resolve all the folks out there that say they haven't been paid, whether it's the University of Iowa or the tiny little programs in some of the other areas. How do they fit in?
Well, we have been working very closely with all providers who bring that to the attention of the Medicaid program. And
Right.
so we have an
I'm just saying,
escalated
how does that
process.
fit into the cost savings?
The cost savings is based on what we project will be paid for the fee-for-service and the managed care capitated payment for the managed care program. So it just really depends upon what the appropriate reimbursement for the providers are. So I can't really speak to
So there's
an
still an
individual
appeal
provider.
process. There's still an appeal process, many of them. I think there's a wide variety of providers out there that still have concerns about their reimbursement in a wide variety of services. So just wondered how that played into your savings, is what I'm asking. But you're saying it's basically in projections.
The state fiscal year 18 is a projection from December of 2017.
So they're still out there fighting for their reimbursement.
So as we move forward in state fiscal year 19, and we actually have actuals for state fiscal year 18, whatever
But there
amount,
could be still
whatever
some of those in
amount
the
that is
appeal
paid for
process
those
as well.
providers, then would be incorporated in that state fiscal year 18 actual amount.
So are outcomes figured in that as well? So
When you
Is
say
that-
outcomes,
So when we start managed care, this was for healthier people,
Mhm.
to make sure everyone is healthier. Where is that evaluated in this as well?
in the cost
In
savings?
the cost savings as well? Because we were going to save money and then everybody was going to be healthier while we were
I think
doing
we're
it.
ensuring a sustainable program, and we ensure healthy Iowans, and you improve the health outcomes of those Iowans. So that's the focus. As far as actual outcomes incorporated, 140.9 million, that's not part of the calculation as far
It's
as the
just about the
outcomes. No, it's not just about the money, I believe. I think we were asked to provide methodology on how we calculated cost avoidance or cost savings. So these are the calculations and the methodology that we moving forward with to determine what that savings or cost avoidance number is.
So the still pending payments are still out there. We still don't know how those fit in to the,
As I articulated,
Calculation.
once an appropriate reimbursement is made to a provider,
You can ask
whatever that
yeah.
outcome is, that will become part of the state fiscal year 18 actual expenditures, which will be then incorporated into that number. But for today, I can't address what may be outstanding or what may not be outstanding, because you could also have IBNR that could be included as well. So there's just those types of calculations that aren't in this number, nor should they be.
So I just want to understand the numbers
Yeah.
even more, because that's how I operate. But, so 4.9 in fiscal year 15, at a 1.05%, at a 5% run rate would mean that in fiscal year 18, we would have expected to spend 5.67 billion.
Approximately correct.
And you're saying we're going to be at like 5.5?
No, you take a look at the total. That 140.9 million is the state general revenue piece. So the actual total dollar amount is greater than, so that total amount, so the 140.9 is just a general revenue amount.
So what you had said was our state expenditure in fiscal year 15 was 4.9 billion.
No, I said the total expenditures without MCO was 4.9 billion. I do not know what the FMAP was back in state fiscal year 18, so I can't address what the state general revenue piece of that was, nor the fee fund piece. That was total expenditures for state fiscal year 15.
Well, we know what the FMAP was in fiscal
Sure.
year 15. We could figure that out.
Absolutely.
Okay.
If that's something that we would like to understand, we can certainly have that
Well,
information.
I think to get the real picture, we need to. I mean, that would seem like that would make it actually complete. So, because otherwise we really can't tell if we saved any money.
Because that's the federal match.
Right. So I just want to make sure that we're all like getting, I understand the numbers are complicated, I totally get that, but, I mean, if we're saving like minuscule amounts of money and Iowans are feeling like they're getting poorer care, then we have an issue. So, and I know that we have that FMAP from fiscal year 15 that we can figure out. So, because otherwise, what I would figure if it was 4.9 at a 5% spend, or at a 5% trend rate, would be that, you know, we would project it out to spend 5.67 billion, and if we're saying we have $140 million savings, then we would be at like 5.5 billion. I mean, those would be the clear numbers if we had all that information. So, I mean, I think, you know, this is such a huge investment for our state that, I mean, I think everybody deserves to have all that information out front. And it's not that we're all on board with, we all want a sustainable program. But Iowans also need to know that if this isn't sustainable partly because we don't have the revenue, then people need to think about what that means and what they want the state to look like. And so I just think it all needs to be on the table.
I couldn't agree with you more. I think that I have, been very open about transparency. I believe it's important that we understand what sustainability means. I think it's also important to understand what those decisions have to be in 3, 5, or 7 years, because we're not talking about women and children.
Right.
When you take a look at the program, the majority of the expenditures are for the most vulnerable population in this state. Long-term care represents almost 50% of those residents are paid for by Medicaid. That number is going to increase. We have 7 HCBS waivers with those vulnerable populations. That number significantly increases. So we have to be prepared to have the sustainable program so that we can continue to provide those services to those members as well as others within the Medicaid program.
Yeah, I agree, and we have increasingly complex treatments coming out as well. So
Absolutely.
It has a huge impact.
Pharmaceuticals has a tremendous impact, right?
Yes.
You know that,
Yes.
absolutely.
Well, we also need to have providers remain in service as well. I mean,
Absolutely.
I think it's great that the director was visiting with the people in Waverly, but in 2 months, I'd like to know where that's at this point too, or 5 months. Because if we don't have providers, this is all going to be much more complicated too. I'm from rural Iowa.
Absolutely
so
agree with you.
Rural Iowa wants to make sure that those people are getting services as well. And when we're talking about it, you know, the aging population, I understand where Medicaid's headed. You know, we're all on that road to understanding where the direction is for what happens with Medicaid. But if we're not going to provide the services, that says something about who we are.
And I think we have to be prepared too. We're not certain and really the unknown that may, from a federal perspective, what changes may occur. So I think every 56 Medicaid programs have to be prepared for whatever that might be.
And the FMAP was different, I would think, there was a big difference.
That's why we went to total cost, because when you just try to isolate those individual components, it becomes too complex. So you take a look at the total Medicaid cost to total Medicaid cost. Because you're right, every 1% change in FMAP, if you have a $5.6 billion program, that's $56 million. That's all general revenue.
So that's why I say, when you say you have $149 million in savings, that's kind of hard to say too. I mean, because it is complex, and it is, we still have to think about who's getting services or who's not, or who's out there not getting reimbursement and who's not. That's the other piece of that. Don't we have 2017 actuals? I mean,
Well, we're going through 2018 because we want to take, we're at the
okay,
end of
so
2018.
how does 2017 fall into this? Do we have anything with them?
Well, state fiscal year
Okay.
17, we do have, and that's factored into the analysis with the 5% growth from state fiscal year 15, the actuals for state fiscal year 17.
But maybe seeing that on a separate level might be helpful as well.
We're not going to have actuals for state fiscal year 18 for
I understand
quite
that.
some time.
Sorry.
Thank you. Yeah, I have a question. So does the savings include what we're paying the MCOs then to administer the program?
Yes.
Okay, can you say what we're paying each MCO, or is that?
The capitated rate includes a component of the capitated rate because there are different cohorts or populations that we provide services to. So those are known as cohorts or rate cells. So there's a different per member per month for each of those cohorts based on the acuity and based on the population. So you want to kind of group your members in like circumstances or behaviors so that you can have an appropriate per member per month that is paid out in that capitated payment. So a capitated payment, I won't go into a lot of detail because that's extremely complex as well, but a component of the capitated rate not only includes an amount for acuity or medical costs, behavioral. It also includes what we call general admin, so that would be your traditional pens, paper, pencils, salary, rent, those types of things that the managed care organization has to incur. But it's also including a component from care coordination / quality improvement activities that the MCO provides too. So that piece is as well in that cap rate. And I don't have the particular breakdown of the cap payment relative to what that admin versus care coordination versus quality improvement activities. I don't have that with
That's the only
me.
money they're receiving? I was thinking there was like a lump sum amount that they were given to administer the program.
No, they're paid based on utilization. It's based on member
They've got an
months.
administrative fee
Right,
in there,
so
that's in
the actuary develops those capitated rates based on actual experience of the members, utilization, the number of members. So for example, and that payment is all inclusive, so and that's what risk is. So the managed care organizations have to manage the care of those individuals. This is their per member per month, that's what they get, based on those different populations.
I understand that. I was just thinking that there was an amount up front that they were given.
No,
to
there's
administer,
just a
and
per
that
member
was-
per month, and if they have 5 members in this particular rate cell, they get 5 times that per member per month, and that's their payment for that particular cohort.
Does that vary based on the MCO?
The, again, getting into detail of capitated
They're separate
rates.
contracts,
They're,
Each
it,
contract is negotiated separately.
well, the
so-
contract's negotiated differently, but the majority of the contract is the same for the MCOs, because from my perspective, you want to have the same requirements, same outcomes, same metrics, same performance requirements for all your MCOs that you have in the state. So from a rate perspective, what happens and how they develop that is there's what they call a base rate that is developed. That's the same for the MCOs. However, because of the acuity of the population, some are sicker than others, right? So there's an acuity or adjustment made to those rates. And then that is somewhat different for each of the MCOs, but it's strictly based on the acuity of their population, and what the actuary projects is that acuity. Because when rates are set, they're set with trends, and that 6 months through the next year. So that's how that particular process works.
So what are they doing to get them? What are some of the MCOs?
Well, I think overall, not just these MCOs, but take a look at a managed care program overall.
No, I want to know why specifically to Iowa. What are they doing to save us this money?
Well, you have effective care coordination, case management, coordination of care across the membership. So from a managed care perspective, that's why you have the behavioral, the medical, long-term support services, all those within the managed care environment so they can coordinate that care. And it's really effective utilization. You take a look at what's driving the cost. So you take a look at, reducing hospitalizations and ER visits and those types of things and getting the members to the primary care physician more, which reduces that type of cost.
It's not just that it isn't happening,
No.
because I do hear that from some of the, and then where are we at, July 1st coming up? So where are we at on the contracts? I know that it didn't get budgeted.
Still in discussions with the
and,
managed care organizations relative to
We
July
left 2 months
1st.
ago or whatever, first part of May. We don't have contracts.
I'm still in discussions with the 2 MCOs relative to the contract for
And how's that
19.
going to impact the savings that we've got here?
I'm still in discussions, so I
we don't
don't
know.
know what the impact is at this point. Obviously, there will be an impact, but I'm not, do not know for sure or certain what that impact is at this point.
But just so I'm clear, one more time, this 140 million that we're kind of estimating as savings, is that total since the inception of?
That's for state fiscal year 18.
That's just for fiscal year 18. Now, if we talk about how much time it's cost the department in this changeover, and if we talk about how much it's cost physicians and hospitals and stuff in terms of time to be dealing with 3 different MCOs and then 2 and now 3, I mean, I'm gonna guess that those costs would be exorbitant. So, and I only say that from the standpoint of like lessons learned, because I know from my institution's standpoint that we put an enormous amount of people and time into managing this change, and then it changes again, and now it's gonna change again. And so I'm guessing it could almost be a wash in terms of overall. It might be as one for just this particular, the DHS, a savings, but across the state, there's a lot of time and effort that's been put into it. So, and I mean, again, every time we change MCO contracts, it happens all over again. So,
Which that has an impact on people not in Medicaid, because your providers are impacted, and everyone out there that aren't part of the Medicaid program are still feeling the impact, and especially if they have to reduce services and don't have, those provided in their communities, that's going to have an impact as well, or costs will go up. I mean, I see all agencies talking about just the billing process alone has been a phenomenal change, and go from one billing place to 2, 3, and then now we're going to have a new one. So, I mean, those costs are going to be out there for the rest of us as well.
Anything else? Thank you very much.
You're very welcome. Thank you for your time. I appreciate the opportunity.